Carl, you good? All right, everybody, welcome to the regular scheduled Curry Health District meeting for the month of October. Thank you for citizens and staff joining us, and Ms. Trish. Good to see you here today.
Good to see you back too.
Thank you. If you guys have cell phones, wonderful. If you could silence them, that'd be great. We'll get right into this. Open the floor for any citizens or staff who would like to have a question, discussion, comment.
I have a comment.
Sure.
My name is Stephanie Martin, I live in Crystal River.
Stephanie.
I have a comment last month's comment by the CEO about something she saw on Facebook that said how great the visit to the ER was. I don't think, first of all, it wasn't on Facebook, it was a Google review where you Google and get, call us, directions, reviews. It's one of 23 reviews over the past 3 years. I don't think these are good use of anyone's time or money to bring these things up. I mean, it's how many thousands of people have come in contact with the hospital. You pick one, the rest of them are like, the hospital was the worst day of my life, they almost cut my arm off, do we want to consider those to be valid? I don't think so. So my point is that I think that this, I'm disappointed that this group doesn't use more rigor in their analysis. There's a huge database in Oregon called the All Payers, All Claims database that tracks every single claim that goes to the healthcare system. You can find out how you're doing, who's out there, who lives in Curry County, where they're going to the doctor, what they're getting seen for. You can look at every single claim that runs through the Oregon health system. I don't think you need to look at social media to see how you guys are doing. I really don't.
Additionally, you can
I'll let her on the floor for 3 minutes.
talk about.
So I think, there are a massive amount of data out there. The federal government has gone to something called evidence-based decision-making. That constitutes the body of evidence. It's real data. Use data to make decisions. You don't use social media to make decisions. For Oregon, there are a ton of great healthcare data out there that you guys would be wise to, Carl's team should be able to do it. I think you can get a better picture of how you're doing with a lot more rigor than pulling stuff off social media.
Okay.
Thank you.
Thank you for your comments. Would you like to say something, sir?
I'll see it at the very end.
Okay. Okay, anyone else? Staff? No, we're good? Okay, thank you, Ms. Stephanie. We'll move on here to meeting minutes. Anyone have any thoughts there? Go. Okay.
I move to approve the minutes as submitted.
I'll second.
Okay, motion is second. All those in favor?
Aye.
4-0, Cheryl. 3-0, sorry. Okay, consent agenda, staff board has had a chance to read this. Should we like to pull anything out? Do so, if not, take a motion to accept the consent agenda.
I'll make the motion to approve the consent agenda.
Second.
Motion is second, no further discussion. All those in favor say aye.
Aye.
Okay, Doc, the floor is yours.
Okay, so for medical staff report and update, a couple of things. So we're just going through our continual process of updating policies and procedures that we need to do. Some getting things in line for the opening of the new emergency care center and workings. Also just having sort of an emergency call schedule in case we do have obstetrics emergencies here. We have people that we can call for that if we need extra hands. Dr. Manueli, who is the chair of the medicine committee, has resigned from that position, just focusing on other things right now, and I think that's just too much of a commitment right now. And Dr. Needens, who's been on several of our committees and been on the medical executive committee meeting as well, I think is feeling some committee burnout, and so he has resigned from a couple of his positions as well. So Dr. Lauder, who's been vice chair of the medicine committee, will take the chair spot, and she'll be a member of our medical executive committee. We're also working on just updating our delineation of privilege forms, so when a provider comes to the hospital and applies for privileges of the hospital in a specific specialty, we actually have a list of all the procedures that we say, yes, these are approved procedures that you can, request to have privileges to do. And so we've been updating some of those for like nurse practitioners, ophthalmology, orthopedic surgery, and also podiatry. We did interview a podiatry applicant, which pretty positive feedback from everyone that I've spoken to about him. He's not available to start until next year, but I think could be a really great addition to our network and a service that we don't provide here currently. I think that is it for my report. We've added a couple more new emergency room docs who have been doing a couple shifts here, and will start working in the emergency room in Brookings once that's opened, who have been doing a great job. So we're happy to have some new people.
Good, great.
You'll excuse me, I have to leave.
Best wishes to your mother.
Oh, thank you.
Mr. G, the floor is yours.
Okay, try to make this short. The income statement, fiscal year to date is shown up here. And I'm just going to highlight a couple of key things. The first thing is, you can see that the net margin fiscal year to date is a negative $23,781. The primary causes for that are seen by the other highlighted items on here. The first thing is that net operating revenue, mostly composed of patient service revenue, is off of budget by 6%. That said, it's 4% above the same period last year. So better than last year, not on target budget-wise. And that is despite the fact that operating expenses are actually 2% below budget, which is a good thing, and 9% above prior year. So the revenue variance is the negative 6% is my, whatever you want to call it, gestalt or big picture of this whole thing is basically we have a major revenue problem and we have a contract labor expense problem. And the revenue problem, at least this fiscal year to date, we've had delays in starting up a budgeted echocardiogram program. We've had delays in starting up physical therapy, increasing our capacity in physical therapy at CMC. I'm pleased to report that we have moved into a new treatment room for PT down at CMC. We have over $20,000 worth of equipment, which was donated by the foundation, or funded by the foundation at any rate. And
Does moved in mean started or just literally?
no, it's in, started. Patients are getting service. The budget issue there was that we had determined that we weren't seeing as many patients as wanted to be seen in physical therapy in Brookings, largely because the facility was inadequate and the equipment was also. So we've now solved that problem, but that didn't fire up until a couple weeks ago. So we had resolved it. It just was delayed. That explains the revenue being off of budget in some ways. And then finally, major issue in the last month in particular was we've had essentially 2 FTEs of surgeons gone. So we lost, in excess of $500,000 of revenue related to surgery in September because of that. And so as I said, it's a revenue problem, and the expenses other than contract labor are behaving well, but contract labor is still an issue. And Jan, I don't know whether you want to add anything to that. Okay, key statistics which kind of add to this explanation. Some good news is the inpatient service volumes were up in September above the 12-month trends, 4 and 5%. The ER visits were 7% up. That's the good news. On the not good news, and largely reflective of the surgeon issue we talked about earlier. Office visits are down 11% off of the trend. Ancillary visits, this is the first time this has happened in my memory, is ancillary services were off 6%. And then finally, surgical volume was down 23%. Those are just the statistics. That's reflected even more in the revenues. And if you look in the surgical lines up there, you'll see the mix of inpatient, outpatient, and endo. Endoscopic procedures are simple, quick, not high revenue generating procedures, largely diagnostic procedures. Where an organization such as ours makes its revenue is in, quite frankly, the outpatient surgical cases. And you can see that was off 42%. So that is the statistical story. Inpatient, the income statement trend looks like this. You can see the green bar, which is the net margin, is a negative 191 in September. We were running positive for quite a few months, although as we reported, we've been below budget. We were running positive, but we're below budget. In September, we're running negative and we're below budget. So this trend is a major issue. Balance sheet, cash is down $423,000 from the prior month. Again, better than last year, so we do slightly better than last year, but we're not hitting our targets. Days cash on hand is at our target of 30. That's our minimum target. In fact, it's slightly better than budget. The reason that's true, even though I've showed other things being off of budget, is simply the way the days cash on hand ratio is calculated. You divide the cash by the average cash expenditure per day, and we have been able to keep the cash expenditures per day lower. So we were able to keep that at 30 days. And then one other key statistic for the balance sheet is we have 16 days of operating expenses and accounts payable, which is pretty good. The goal would be to keep it below 30 days, which most vendors would respect.
Simple question, it doesn't add up too much, but when do we get, we collect taxes around the end of November, do they wait till mid-December to pay us?
We start collecting taxes in November.
Pretty quickly then?
Yep. Key financial ratios, you'll see a lot of red there reflecting what I just reported. The 3-year annual trends are up. We're generally good. Cash flow margin is flat, but the quarterly trends, which I've turned red all the way down the line, except for long-term debt to capitalization, which is flat, and current ratio, which is slightly up. And the current ratio is up because we're paying those accounts payable faster. And that is my report.
Question. We at some point are going to reconcile Medicare, and while we had to pay, I believe it was $800,000 last time, clawback, we should be getting money back from them this time, the next time we reconcile with them. When is that?
No, I wouldn't say what you just said.
Oh, okay. But I'm saying, when do we reconcile with Medicare next time?
We're finishing a cost report as we speak.
Okay.
Hope we got it done this afternoon.
Because I'm thinking that, looking at the revenue we had the last couple months, that's going to have a big dip in cash then in December, January timeframe.
Correct.
And we're probably going to get down in the teens, and I'm thinking that, depending on how it comes out, we may actually get some cash from the government. Can't count on it, but if we did, it would be in that same time period.
It would be in that same time period. I'm trying to take your sentence apart word by word, answer it as if I were in court. I don't want to represent what I think that the cost report's going to look like. We had contracted to have a cost report tool. We're not yet using that tool. Right now, we're finishing the audit. The final step of the audit is the cost report. We were answering some questions about how expenses went during the last fiscal year. Stay tuned, I really don't know. I really don't know. We will know probably in the next week.
Very good.
I had one question, I had written it down yesterday and forgot to ask you. Our accounts receivable, net accounts receivable is quite a bit higher than it was a year ago, and it's 35% higher. And our sales, our revenue hasn't been going up by 35%. So just from 30,000 feet, do you have an explanation?
No, you sent me that email this morning. I started to answer it, and then I started getting into the weeds of trying to answer it correctly. So again, I'd rather not just throw it out. I don't think you can compare the percentage change in accounts receivable with the percentage change in net revenue. So, and I can explain that more later if you want to come by, I'll do so. So one of the things I just point you toward, though, is if you look at last year's net accounts receivable, and then you remember that I made a $1 million change to that number after the year was over as part of the audit. I would argue that last year's net receivables were undervalued, and the change in that valuation was part of the year-end/audit change. So
But you don't make your adjustment to match the audit then? You make the adjustment to match the audit, but you don't make it in the same period, you make it.
that's correct, that's correct.
You
And
make
so,
the adjustment in December or whatever.
yeah, no, you're onto it, because basically what's true is what I was doing when I stopped trying to work on the problem was figuring out when did that adjustment to net AR
Yeah,
occur?
that's most of it right there. That's why, and that answers my question right there.
Yeah, and that's part of the problem with doing the month-to-month comparisons looking back, because last year's version of this month, didn't reflect the year-to-date adjustment in the audit. And why the month-to-months need to be taken with a grain of salt. And that is a big grain of salt. Okay.
Okay. Mr. Chairman, any questions? Brian, anything else? Good?
Oh, good.
Okay, excuse me. Everyone's okay, and then further questions, so take my question.
I move to accept the financials as reported.
Okay.
A second.
I have a motion and a second, no further discussion, all those in favor? Aye.
Aye.
4-0 there. Okay, Ms. G.
So you have my written operations report. I do want to just touch on the Curry Medical Center Emergency Care Department, the preparation that's been ongoing. But before that, I want to start with a couple of positive comments, as I like to do with each one of my reports. The first is that this week alone, unsolicited, 2 longstanding community members both approached me and commented on what exceptional service they had in 2 different areas of our network. And although I agree with Mrs. Martin's statements that you absolutely need to consider additional data, we are on a service excellence journey, and it is important for the board to be aware of the perception of the community and our reputation. And I would surmise that, given the feedback that I get on continued rounding and, again, unsolicited feedback, things are looking very, very positive. Another positive that I want to share, and it is related to the emergency care center, is that pulling the trigger in late September was a bit of a task for our management and our staff. There was a lot of critical paths that needed to be completed prior, and I really want to commend under Megan's leadership. She has effectively pulled this team together, and they are working so well together, demonstrating our value of teamwork. it makes me just so proud to be part of this organization and part of this initiative. And if you actually want to see it working, you can come by on any Wednesday, except next week it'll be Thursday morning at 7 a.m. And we actually have a detailed work plan where every single department is reporting out accomplishments from what they had to accomplish from the previous week, any barriers that we need to resolve, and then looking forward to the next week, what needs to be done. But really, people are pulling out all the stops, and I have to mention, we do have staff members that are working now 7 days a week, extended hours, making sure that this licensing survey we're prepared for. So lots of effort going into that. We've been doing a lot of in-person public relations presentations. I've been now to all the city councils, Seroptimus, I was at Gold Beach Rotary, I was at Port Orford City Council, and feedback has been very positive that the presentations are informative, and being able to answer and field questions has been a great opportunity. I do have an event planned down at Brookings tomorrow, and then we have our event scheduled on the 27th to have walkthrough tours and those, for those that have supported us. So things are moving in the right direction. I think for all purposes, we are on track. We definitely have some staffing considerations that are difficult, some of the night shift positions for registration, and MCARE is working feverishly to fill the emergency room slots. So things are still in the works, but we're very confident that we'll be ready for licensing on November 5th, 6th, and 7th is when Oregon Health Authority is scheduled to be here. So before I move into any other topics, are there any questions related to that?
Not that one specifically, I do have a question about the 12-hour hold.
We can move on to that. So Oregon Health Authority was here, maybe it was 5 weeks ago now, recertifying us for our 12-hour hold and transport. In that meeting, they indicated to us that if in fact an individual needed to be placed in a hold situation, our medical staff can remove somebody's civil rights for up to 12 hours. And after that, we're not really able to continue to extend that hold. We don't have the rights, we don't have the means to evaluate and treat psychiatric patients
And
here.
that's based upon a provider's.
Judgment,
Yeah.
yes. So there are basically 3 entities that can place an individual into a hold situation. Our medical staff can place an individual on a 12-hour hold. Prairie Community Health can place people on what's called a director's hold, and then the police department, they can place people on holds. All 3 avenues kind of lead to the same outcome, which is how do we get this person to the appropriate next facility for treatment and evaluation and treatment if necessary. And in that meeting, the inspector shared with us that, it's been determined that if a patient is placed on a hold and they are in danger of harming themselves and themselves or somebody else, and it's determined that 12 hours has gone by and the situation hasn't changed, but there hasn't been placement found, they would expect us to continue to hold that individual. Now, we've learned subsequent to that things will change a little bit in that if in fact we find that that individual is still in danger of harming themselves or somebody else and we're encroaching on that 12-hour, we're to contact Prairie Community Health, who would then put the patient on a director's hold. That director's hold could be as long as 5 days. So we're faced back with this situation where we'll have patients in our emergency room for extended period of times, potentially. So we are exploring options. One of those options is potentially, I'm not saying we will or won't do this, but I'm learning about telepsychiatry. The thinking is that if in fact we're going to have people in our facility for extended periods of time, and I still believe that it's not right that they remain here for any period of time without an evaluation and treatment, could we use telepsychiatry that could actually do an in-person evaluation where a physician and our physician are evaluating that patient together through telemeans, whereby the psychiatrist can actually consult more appropriately and help our physicians make treatment decisions that they wouldn't otherwise make on their own. And in that situation, could we actually help these patients more during their time while they're here, and maybe even get them to to a stable situation where they don't ultimately need to remain on that hold. So we're just exploring our options right now. Again, when CCO 2.0 goes into effect in the first part of the year, contracts are going to change with the Medicaid payer, and we may have other opportunities to potentially provide more services to those individuals that we may end up ultimately having anyway. So, any other questions related to that?
No. Just, the telemed, I don't know enough about it or anything about it, I should say, with this telepsychiatry. I guess you put a monitor in a room, and someone who's not potentially mentally stable is supposed to talk to a monitor?
Well, it's not just the person, obviously, we have our staff with that individual, and yeah, you do, you bring in a monitor, a computer, and obviously, we have to get those individuals that are threatening to harm themselves to a calm enough situation where they can participate in that evaluation, but telepsychiatry is definitely becoming a means by which small communities like this that have no access to psychiatric services do, and I do believe Curry Community Health uses telepsychiatry too. So we do have a lot to learn about it. Again, I'm not jumping in with 2 feet, but I think we need to have some plans to be able to support our emergency room folks when these people are here for an extended period of time, and that would be an option for them.
So if Curry Community Health or the Sheriff's Office has a potential patient, are we the only hold? I used to said Curry Community Health has hold also
Yeah, but we're the whole facility.
for all 3?
Yep. Yes. Now, obviously, if an individual has committed a crime, I guess they could be held in the jail cell, but that's not much better than being held in our room. It's not a good option.
But in order to see a telepsychiatrist, they would have to come here. That was the
If
only
they're on a
option.
hold, they're being held here, yes. We're not transporting them out for telepsychiatry at Curry Community Health. I do not believe that Curry Community Health's service is one where it's on-call 24/7. We'd be looking at an on-call contract with the telepsychiatry company so that in these critical situations, within 15 minutes, a physician could get in touch with a psychiatrist or a psychiatric nurse practitioner. Both are used.
I don't remember if there's a conflict prior, but do we kind of have a mutual understanding with the city or sheriff's office that if someone does get brought here, that we could potentially get some help in the middle of the night?
They definitely do respond when they can. They're doing their best not to drop off extremely violent, folks. And the trouble is, sometimes you can't tell what's going to tip somebody off. So we've had situations where we've had to call the police department or the sheriff, and they have responded, and I do believe they do. It's a treacherous moment when that's happening, and we don't have them here. Our county does not have law enforcement resources to just place somebody in the room with an individual.
Maybe, I don't know if you just started here or right prior, but we had a gentleman tore up the old nurses' stations in the old hospital in the middle of the night because there was no one to stuff to do them.
We've had people tear apart our hold room. Walls kicked in, doors kicked in, and these people, they can obviously turn violent, and we're not asking our staff to put themselves in harm's way. I mean, really at that point, we have to call the police and if necessary, let the people go, just to keep our staff safe. It's not a good alternative. Obviously, we're calling the police to say, we've got this situation, and they apprehend very quickly, but we've had some very challenging situations. Yeah.
So we only have the one hold facility here, so when we open the Brookings emergency room, there won't be a hold down there, so if somebody needs to be held, they're gonna have to be transported here.
Yes, so we've already worked out with police and Curry Community Health that any individual that would be transported here will continue to be transported here. If we have a situation where an individual walks into the emergency room at Curry Medical Center, all efforts will be made to transport them up here very quickly. So again, depending on the safety situation and our assessment of what's best for the patient and our staff. But all the plans are to keep them here, not down there. We have no space, and we don't have safe space to keep anybody down there. So you have the rest of my report, I'm not gonna go over every single thing. I do wanna have a shout out though, because 3 staff members of this organization presented with me at the Office of Rural Health, Rural Conference. And we did get our evaluations back, 72% of the participants in the room, and we had about 60 folks there, gave us a 72% top box, an excellent rating. We had comments made that we were the best presenters there. Obviously, it's anecdotal, it's one person's opinion, but I'll take it because Sunny Day, Nicole Legg, and Gail Meidinger, and myself, we're not public speakers. Obviously, I do much more of it than they do, and they represented us really well. So, there's a lot to be proud of.
That's wonderful.
It is.
How about the other parts of the conference?
Other parts of the conference were good. Brian Lee was there, you know, he did his normal thing, and that was fun to see. Other presentations, I didn't necessarily attend them. Nicole attended many of them. She felt some were better than others, and, you know, it was a good conference according to those that attended the whole thing. I only went up to present the day that I was there.
Okay.
On these public health services, are we going to see a plan before we actually commit something to the county?
I'm not committing anything to the county. Right now, we are just learning what it is that they need, and we are trying to determine if there's any way that we could close any gaps. I can tell you, Brian, as I shared with other board members, we are not in a position to take on and to build programs. We need business plans. We need to focus on the emergency room, getting that open and stabilizing that before we can turn our sights to other projects. And I would imagine this would be a project. I'm going to speak with Julie Schmelzer tomorrow about options and things for their consideration, but we're really not in a position to be able to take on the tasks that public health requires.
Yeah, I would bring it up because this has been a tar baby for years and years.
Yes.
And I think we have to be really careful on this.
Oh, yeah, absolutely.
All right, Jane, thanks for your office report. Do you guys have any other questions? Okay, open the floor again to staff, citizens. Yeah, got some new faces sneak in.
I have another
You
comment.
betcha.
Let's talk data comment again. I noticed you guys are, by your own love of this bizarre survey that measures very little, that you're now at 3 stars. And that's what happens when you use data with doesn't mean anything. So that's what happens with those kind of databases. You're no longer 4-star place.
Okay.
But it's probably a function of the way the data are collected and they're not representative. So you get numbers that move all over. Sorry.
No, I'm just your floor.
But I'm just saying, I'm going to keep pushing to use data and use it well, and there's a ton out there. It's public access, it's all free. It's not all free, but it's available.
Thank you. Anyone else? Okay, thank you guys. We have for review, the board does 4.4, information resources for a healthy lifestyle. So that's for review this meeting, and then we will address it the following meeting, which will be in Port Orford, I show. I was headed there about an hour ago. You did too?
I had it on my calendar this month.
We'll move in here to board process. Okay. I guess we'll have, anyone have any comments or anyone want to discuss this?
The health needs assessment, that's an ongoing.
Every 3 years.
We don't wait till the 3 years is up and start a new year. There's a group that's still together and working on it.
Yes, so I'm part of the county-wide health needs assessment, but it's tricky, Bo, because our calendar doesn't mesh up necessarily with the CCOs or with other agencies that are required. So this is really a tickler for me to say, this is gonna be due in June 2021. I need to identify an individual and a resource to begin that work again.
It takes about a year, right?
It takes about 6 months, if done well with focus groups and, yeah. So it's really, that caught my attention. Okay, that's due. But this is June of 2021. I still have June of 2020. This is 18 months prior. Okay. I'm
It's
not-
2021.
But I think that this, we have this on the board work plan early.
It's on there every year.
Oh, every year. Okay, thank you. Thanks for the reminder.
Got a year and a half to.
Yeah, thank you. I've made you feel better already. God.
So, I missed the last meeting, was this brought up here, last meeting, B?
No, but I think that this was related to some discussion about if the two board members, if one can't attend a committee meeting rather than cancel it, substituting in an alternate individual, right, Cheryl, that's what that dialogue was, so. Right now, it just says two board members, so I'd imagine, the way it's written, we could just,
But specific board members were appointed for specific terms, so.
Correct.
Well, I would think for everything but the financial monthly. I mean, we are usually good with scheduling, so the two people can attend.
I think for the most part, besides just completely being physically out of the country, we've shifted a little bit here and there to make sure we had 2 air meetings. I called in yesterday.
A month ago, we were short, but, maybe so that you had two board members, or you don't have to necessarily appoint an alternate, just be able to add one. And I'll call them. Just so we can have a meeting. Unless you want to appoint somebody specifically.
I would know, just have to have it written, wow. In the absence of the appointment.
Sure, where do you see on here that says requires 2?
oh, under,
Is it a
It's
different policy?
composition under each,
Oh, under each one.
yeah, composition.
D.
I'd actually question, should it read 2 elected or selected board members versus just 2 board members?
It's more flexible this way.
Oh, very much.
You're not, because you've appointed, so.
Yeah, well, because you should say 2 appointed board members.
It-
I'm not saying should or should.
It could, or you could say two appointed board members or an alternate or something if you wanted to change.
I don't think we need to make decisions today, but how about I give Bill Charney a quick phone call? Let's quiz him what he says.
I think it is important that we have the flexibility to conduct committee meetings.
Yeah.
Yeah.
Because the alternate is then we conduct committee business here with the full board, and we've done that for a long time too, so.
So it's back on the agenda for next.
Yep. Okay. I'll see you. Consent agenda, financial reports. This was this a discussion last meeting also?
No.
No.
We ran over last time.
Ran over.
Had a lot-
Oh,
lot of
gotcha.
stuff on it.
We're there, basically, majority of the time. The question actually would be more for Brian, Karen, and Lori.
I like the idea, but I think at this time we need transparency with the public. I love the idea.
I think we need to continue what we're doing for the time being.
That's three, so we're good. Okay.
So no action is necessary.
No, great, I changed things. Great. Mission statement, Jenny, you had a proposition from staff.
Yep.
Under it.
So, at our service excellence training, we were reviewing certain important information by which our staff are guided. So I think we were talking about, when a new employee is hired, what information are they given? And we started really talking about the mission, vision, and values and really how important that was. But I recognize that the current mission statement that states Curry Health Network exists for healthy communities in which there's efficient quality healthcare. If I am an employee in a given situation where I have competing priorities, and I look at that mission statement, I'm going to take the most efficient route, but not necessarily the most compassionate route. And because we were in the service excellence training and we were talking about compassion, it really begged the question, is it our goal to be the most efficient place, or is it our goal to be a compassionate place where people receive health care? And so the management team came up with a recommendation to revise the current mission statement from Curry Health Network exists to Curry Health Network fosters healthy communities in which there is compassionate quality health care. Because remember, this is the beacon by which our employees and we make decisions about what it is and how it is we should go about things. And then below that, you would see what our current shared values are, and respectfully, they would like to include the word always, because we are making a commitment to our patients that we will always do certain things, and this kind of solidifies their commitment to always demonstrating these values with each other and with our patients. So it comes as a recommendation, and the reason I bring this before you in this manner is because we're putting together the education training for all staff next year, and part of that training is the mission, vision, and values. And so if we're going to train to these things, we want to train to current verbiage. And so if there was going to be any changes made to this verbiage, we would need to know that for the training packet. So that's how this comes about.
I have a question on the employee survey. I believe, I didn't see the survey this year, I've just taken the results, the summary we provided. Is there a question that asks to outline what the mission and the values and, okay, how did we do this year?
We did better than we did the last 2 years, but I don't remember the number, Bo. I'm looking at Carolyn, I really can't remember. The question does ask, how well does the organization demonstrate its, and we should take a peek at that, but I don't think it was as high as other things that we scored in, but I know it was better than the last 2 years.
I personally
Like the
the
proposed-
change,
Oh, yeah.
the change.
I'll just start. So the values, big fan of always being inserted. I like that. No issue there myself. he said, I think it would be close, but maybe not the same phrase. The proposed revision, I prefer compassionate much more over efficient, so I think that's a great choice of words. The first part you got highlighted there, I mean, I don't have a problem with it, I guess, but like I said, this could all change.
It could change. I mean, these things, you don't want them to change every 3 months, but
Yeah, but I think when a patient comes in the hospital, you want them to leave feeling that they were handled expediently, courteously, that people paid attention to them, and when they walk out of here, even if we didn't solve the problem in that visit, they need to feel that we did everything we could do while they were here. And I think that's more even important than the service you're offering. I mean, the service we're offering is very important, but if anybody walks out of here unhappy because of the interaction they had with somebody here, that's a problem.
But again, if I'm a newly hired staff member and I'm faced with a situation, you know,
2 people at the same time or whatever.
just, yeah, efficiency over everything or anything else. I'm gonna pick the most efficient thing, even if that means I'm gonna tell you very quickly, hold please. Versus taking that extra minute, you know, I'm sorry to make you wait, I'll be back with you in 5 minutes. It's more compassionate. It demonstrates that we respect their time. It's just I think words are important, and especially for our staff to really know what is the beacon that they should be following. And right now, it says we're gonna be efficient. So it values that over other attributes.
I think there's a combination of things too. I mean, I don't want to sit and wait for 30 minutes past my appointment to see somebody. And if somebody's being ultra compassionate and everybody else that day is going to be 30 minutes late, we haven't done the right thing either. So I think there has to be some sort of a balance that we're doing the best that we can for patients. And then sometimes that means there's a delay, but sometimes that means we have to act expediently too. I know nothing bothers me more than going to a doctor's office for a 2 o'clock appointment, and it's 2:50 and I still haven't seen anybody. I mean, is my time less valuable than their time? That's how I feel.
And the worst part is you're in a small town, you know what car he drives, it's not a parking lot.
Exactly. You know, so, I think.
Don't look at me.
I'm just saying that there is an emotional criteria associated with patients, so we have to be very sensitive to it. And compassion is part of it. Being punctual, being expedient with him is important too.
But you can't have a mission statement that, I guess you can. I've read some really long ones and nobody remembers them, so you want it to.
Whereas the
What
first
resonates
part
with
is.
them? And I would argue, Brian, that if you were waiting in one of our offices and it's 2:10, and we noticed tick, tick, you had a 2 o'clock, we can demonstrate compassion to say, Mr. Grumman, we see that you've been waiting, we're very sorry, Dr. fill in the blank. We're late, we can either reschedule or get you a cup of coffee or make you more comfortable. That's compassionate care.
So that's true.
And that makes all the difference. We know with wait times, that's a proven theory. So, look, I know this is a stopgap, but we're gonna educate this and we're gonna drive it home, and I just,
I think they're good changes. I'm saying that it may require a bit more.
it might.
Well, I think we're gonna have a very lengthy discussion, in the near future.
Mhm.
And this mission statement most likely will be affected. I'm gonna assume you guys have a substantial amount of time into just the potential changes of these 3 words.
Nope, packets, the information is due October 31st.
No, I mean, your group of sitting around the table talking about this and discussing this. This was a lengthy discussion with a group of people.
It was part of a 2-day discussion, really, but not about this. It's not like we,
No, I understand.
Yeah.
There's been, you guys have put a lot of thought into this. Knowing that it's coming up soon, that we will be having the same discussions with part of your team. But I support your team if they want to make these adjustments.
line, way better.
Just a thought.
Bo, you've been quiet. Not to call you out.
Well, my abbreviated version is that I wish we were spending this much time on the strategic plan. And that's, as Ryan has indicated here, we're gonna, this may change. Although we're not gonna, what we're trying to do here isn't gonna change. The strategic plan is very important, and we've been hammering on that for some time. But I'm in favor of these, and make the change that Cheryl has suggested to. I'm in favor of making those, and let's run with it until we get the new one done.
I'm in certain agreement, the most important thing we've got coming up is the strategic plan, that has to be done.
I'll make a motion to accept the changes, including what Cheryl mentioned, changing one word, using one word instead of four. I'll make that motion.
Okay.
I'll second.
Motion is second. Cheryl, you understand the motion? All right, no further discussion. All those in favor say aye.
Aye.
Okay. Next board meeting, Port Orford. Cheryl, did you get a location locked down?
It is at City Hall.
Okay, great. And we're good to 4 o'clock, guys?
Yes.
We'll do that, okay. And that is the week prior to Thanksgiving next month, correct? So which would give us the 20th. All right, and the finance meeting will be on the 19th in Gold Beach. Okay. There we go. Other meetings and events, we are on track to do board training in March first week. All right, we go with that, Ryan? Okay. I can't think of, and then we did discuss December, also moving that one, so everyone's on the same page, that'll be on the 18th. Jumping off topic here, but the finance committee spoke with Jenny and Carl about, with the vote last month in regards to moving forward with the emergency department Brookings. Finance committee asked for a revised budget, and we will go through revised budget notices, but we need to come up with a date for all of us. We briefly threw out the first week of December to have a special meeting to go over that revised budget. Cheryl will, I don't know what the timeframes are for notice of public hearing, but we will follow along with that, but we need to set an end date so we can work backwards from that. How's your calendar the first week of December? Go for it.
My earliest date available is the 12th of December,
Okay.
and then I'm available straight through.
Okay. December. Okay. Ryan?
Yeah, I'm good pretty much everything except the week of 17th, 18th, and 19th. But other than that, I'm good. And Christmas, of course, but
Okay. Well,
So do you want to have it in between those 2 days? You've got the 13th and the 16th.
yeah, Jenny and Carl's questions for you. If we do it, 17th, what do you got there?
what's a dead day for
13
me?
to 16.
That mean,
I got 17, 18, 19, I'm
Yeah,
off.
we've got
Oh.
13, 14, 15, 16.
okay.
The 12th, I can be here.
What about the afternoon of the 16th, or is that cramped?
That's good.
you can adopt on the same day, I just didn't know if you had recommendations for changes, if Carl would have time to finish those changes by the regular board meeting, which is what, a couple days later.
It's the 18th,
Yeah.
it's the next
Sure.
2 days.
What time are it? 16?
To be determined, but
Oh.
that after that. Most likely,
I'll just block away.
most likely somewhere right around 3 or 4 towards the end of the day.
Okay. To clarify, this is a budget workshop for you guys, or is that the public budget hearing?
Um,
Public budget hearing.
Yeah, see here.
Hearing, okay.
Sorry, let's see. Okay. All right, anyone have anything else? No, good, okay. Anyone want to touch on meeting evaluation? Um, We are going to we're going to adjourn the regular scheduled meeting and re-adjourn if necessary following executive session. Executive session will be entered under ORS 192.6602I under performance evaluations. We thank everyone for being here. If you don't make it back afterwards,